These are the 5 warning signs of vitamin B12 deficiency that people most often explain away as ordinary aging, ordinary tiredness, or ordinary stress. Some of them reverse completely within weeks of treatment, and some of them, left alone long enough, never reverse at all. Before we go through those 5 signs, there is a number circulating on the internet that needs correcting, because it appears in almost every article and video on this subject. That figure is wrong, and tracing where it came from tells you something useful about how health information gets distorted. The number originates in the Framingham Offspring Study, published by Catherine Tucker and colleagues in the American Journal of Clinical Nutrition in the year 2000. Around 3,000 participants between the ages of 26 and 83 had their blood tested, and about 40% of them showed plasma B12 in what researchers called the low normal range, meaning below roughly 258 picomoles per liter. Low normal is not deficiency. It sits inside the normal band, at the lower end of it. The same study reported that about 16% were near deficient, and about 9% were genuinely deficient. What the actual American numbers look like comes from NHANES data covering 2007 through 2018, analyzed by Joe and colleagues, and cited by the National Institutes of Health Office of Dietary Supplements. Roughly 3.6% of American adults 19 and older are deficient, using a serum threshold below 200 picograms per milliliter. Insufficiency, defined as serum B12 below 300 picograms per milliliter, affects about 12.5%. The American Academy of Family Physicians puts frank deficiency at 2 to 3% of American adults. So, the honest version of the story is not that 40% of a continent is deficient. The honest version is that a few percent of the general population is deficient. Certain specific groups are deficient at rates that climb past 50%. And the symptoms are quiet enough that a lot of those people have no idea. That second part is where this video actually matters. Vitamin B12 is water-soluble, and because every compound with B12 activity contains the mineral cobalt, the whole family is called the cobalamins. It happens to be the largest and most structurally complicated vitamin known, and the only one built around a metal ion. Inside the body, it does 3 jobs that show up directly in the symptoms we are about to cover. It is required for the development, myelination, and function of the central nervous system. It is required for healthy red blood cell formation, and it is required for DNA synthesis. 2 enzymes depend on it: methionine synthase, which converts homocysteine into methionine, and L-methylmalonyl-CoA mitosis, which converts L-methylmalonyl-CoA into succinyl-CoA. Those 2 reactions explain why deficiency damages nerves and blood at the same time. Here is the part that surprises most people. B12 is synthesized only by certain bacteria and archaea. Plants do not produce it, and animals do not produce it either. Animals accumulate it in their tissues by consuming it from bacterial sources further down the food chain, which is why B12 shows up in fish, meat, poultry, eggs, and dairy, and why it appears in plant foods only when someone has added it during processing. Watanabe and Bito laid this out in Experimental Biology and Medicine in 2018. Your body has no pathway to build this molecule, so every microgram you carry arrived from outside. Getting B12 out of food and into your bloodstream takes more steps than any other vitamin. The vitamin arrives bound to protein and has to be released. In the mouth and stomach, salivary haptocorin binds it, while hydrochloric acid and gastric protease work it loose. Down in the duodenum, digestive enzymes strip it from haptocorin and hand it to intrinsic factor, a protein secreted by the parietal cells lining your stomach. That pairing then travels to the distal ileum, at the far end of the small intestine, where receptor-mediated endocytosis pulls it across. Break any link in that chain and absorption fails, no matter how much B12 sits on your plate. Lose stomach acid, and the vitamin never separates from its protein. Lose parietal cells, and there is no intrinsic factor. Damage or remove the ileum, and there is nowhere for absorption to happen. Intrinsic factor also caps how much you can take in from a single dose, at roughly 1 to 2 micrograms, which explains something that confuses people about supplement labels. Out of a 500 microgram dose, only about 2% gets absorbed, and out of 1,000 micrograms, only about 1.3%. The enormous numbers on the bottle exist precisely because the absorption ceiling is so low. The recommended daily intake, set by the Food and Nutrition Board at the National Academies, is 2.4 micrograms for adults 19 and older, rising to 2.6 in pregnancy and 2.8 during lactation. Children need less, from 0.9 micrograms between 1 and 3 years, up to 1.8 between 9 and 13. Those figures already assume you only absorb about half of what you swallow. Now, the detail that makes B12 deficiency so easy to miss: your body stores between 1 and 5 milligrams of it, mostly in the liver, which works out to something like 1,000 to 2,000 times your daily requirement. There is also enterohepatic recirculation, meaning the body reclaims a portion of what it excretes in bile. Stop absorbing B12 entirely today, and those reserves will carry you for years before symptoms surface. By the time your body finally runs the tank dry, whatever caused the problem has usually been in place for a very long time. The first sign, and the most common one, is fatigue that does not respond to rest. The mechanism is straightforward. B12 is needed to build red blood cells, and without enough of it, the marrow produces large, abnormally nucleated cells instead of functional ones. That condition is megaloblastic anemia, sometimes called macrocytic anemia, and it shows up on a blood test as a mean corpuscular volume above 100 femtoliters. Fewer working red cells means less oxygen delivered to tissue, and less oxygen delivered to tissue means exhaustion, weakness, palpitations, and pallor. What makes this hard to act on is that fatigue is the least specific symptom in medicine. It accompanies thyroid problems, depression, sleep apnea, iron deficiency, and 100 other conditions. Fatigue on its own proves nothing about your B12 status. Fatigue arriving alongside 2 or 3 of the other signs in this video is a different conversation entirely. And that combination is what deserves a blood test rather than another cup of coffee. Deficiency can also suppress white cell and platelet counts, and in severe cases, it progresses to pancytopenia, where all 3 cell lines drop together. That happens in roughly 5% of B12 deficient patients. Muscle weakness follows from the same oxygen problem, and it tends to arrive so gradually that people restructure their lives around it without ever naming it. Stairs become something you pause halfway up. Grocery bags get split into 2 trips. The explanation people reach for is age, or being out of shape, or simply having a hard week. Muscle tissue depends on oxygen delivered by red blood cells, and red blood cell production depends on B12. So weakness sits directly downstream of deficiency and usually travels together with the fatigue. There is a second layer to this that matters more than the first, and it is neurological rather than hematological. B12 maintains the myelin sheath that insulates your nerves, and when that insulation degrades, the problems are not limited to strength. Paresthesia, the pins and needles numbness in hands and feet, is one of the earliest neurological signs. Peripheral neuropathy follows. In prolonged cases, the deficiency produces subacute combined degeneration of the spinal cord, which damages both the dorsal and lateral columns and disrupts balance, coordination, and gait. The Office of Dietary Supplements states the point plainly. Neurological symptoms can occur without anemia, so early diagnosis and intervention matters to avoid irreversible damage. Read that carefully because it undercuts the most common assumption about this deficiency. A normal red blood cell count does not clear you. Nerve damage can be well underway while your complete blood count looks unremarkable, and unlike the anemia, nerve damage does not always come back. The third sign is the one you can actually see in a mirror, and it is the most specific of the 5. The surface of a healthy tongue is covered in small bumps called papillae, most of which house taste buds. In B12 deficiency, those papillae flatten and disappear, leaving a tongue that looks smooth, glossy, and deep red. Clinicians call this atrophic glossitis, and when it stems from B12 deficiency, the older name is Hunter's glossitis, sometimes described simply as a beefy red tongue. Pain frequently accompanies the appearance, which carries its own term, glossodenia. Taste dulls as the taste buds go, so food starts registering as flat and uninteresting. Angular cheilitis, the cracking at the corners of the mouth, and recurring mouth ulcers show up in the same picture. The strength of the connection is worth stating precisely. Chen, Tong, and Bao published a case control study in BMC Oral Health in 2022, comparing 236 patients with atrophic glossitis against 208 controls. 68.22% of the atrophic glossitis patients turned out to be B12 deficient. More encouraging than that percentage was what happened next, because the tongue lesions resolved within roughly 1 month of supplementation. 1 month. That is the return on identifying this correctly, and it is why a smooth red tongue deserves a photograph on your phone and a mention at your next appointment rather than a wait-and-see approach. If this is useful so far, subscribing helps these videos reach the people who need them, and the notification bell means you catch the next one. Sign 4 involves color, and the mechanism behind it is more interesting than the popular version suggests. Pallor comes with any anemia, since fewer red cells circulating means less color in the skin. The yellowing is where B12 deficiency separates itself. Defective DNA synthesis means red cell precursors are destroyed inside the bone marrow before they ever reach circulation, a process called ineffective erythropoiesis, or intramedullary hemolysis. Cells breaking down release unconjugated bilirubin, also called indirect bilirubin, and rising bilirubin tints the skin and the whites of the eyes yellow. Lactate dehydrogenase climbs sharply at the same time, and haptoglobin falls. There is one laboratory detail here that helps doctors identify what they are looking at. The reticulocyte count, which measures immature red cells, stays characteristically low in B12 deficiency. In true peripheral hemolysis, the marrow responds by pushing out more reticulocytes. So, a low count alongside high bilirubin and high LDH points toward destruction happening inside the marrow rather than in the bloodstream. Honesty requires a caveat on this one. Frank hemolytic anemia from B12 deficiency is relatively uncommon. In one series of 201 B12 deficient patients, about 1.5% presented with it. Skin also has other explanations that need ruling out, including liver disease and other forms of jaundice, which is exactly why this sign belongs in a doctor's office rather than a self-diagnosis. The 5th sign is the rarest and the most serious, and the popular version of it is usually described wrong. B12 optic neuropathy is real. It presents as progressive, bilateral, painless vision loss, often with reduced color vision and a central or secocentral scotoma, which is a blind spot sitting at or near the center of the visual field. The damage occurs in the optic nerve and retinal ganglion cells, producing bilateral optic atrophy. You will find plenty of health content claiming the mechanism involves blood vessels getting plugged in the retina, and that is not the standard explanation in the ophthalmic literature. The nerve itself deteriorates. Frequency deserves an equally precise treatment. Writing in the Journal of Optometric Education, Roberts puts it directly, stating that optic neuropathy secondary to vitamin B12 deficiency occurs in less than 1% of B12 deficient patients. Less than 1%. Nobody watching this should walk away frightened about their eyesight, and nobody should dismiss the sign either, because of what the outcome data shows. Otta and colleagues published a systematic review in Annals of Medicine and Surgery in 2020. Following 24 patients, bilateral optic atrophy was the most common finding, present in 16 patients, or 66.6%. On recovery, 6 patients, 25%, achieved complete resolution. 8 patients, 33.3%, improved partially. 7 patients, 29%, did not improve at all, and 1 patient, 4%, progressed to complete blindness. Roughly a quarter recovered fully, and roughly a third recovered nothing. The variable separating those groups is time, because as The Lancet noted back in 1998, recovery of dead axons cannot be expected. The same nutritional pathway underlies tobacco alcohol amblyopia, a related nutritional optic neuropathy that has been described in the literature for well over a century. Population averages hide the people who need this information most, so here is where the numbers concentrate. Age changes everything about B12 absorption. Between 10 and 30% of older people cannot properly absorb the protein-bound B12 found in food, which is why the Office of Dietary Supplements advises adults over 50 to get most of their B12 from fortified foods or supplements, where the vitamin arrives already free and skips the first step of the absorption chain. Depending on which definition researchers apply, anywhere from 33 to 43% of community-dwelling older adults qualify as deficient. Bailey and colleagues reported in the American Journal of Clinical Nutrition in 2011 that about 21% of adults over 60 showed an abnormal result on at least one B12 biomarker. Pernicious anemia is an autoimmune condition that destroys the ability to produce intrinsic factor, and it remains the most common cause of clinically obvious B12 deficiency worldwide. It accounts for roughly 15 to 25% of B12 deficiency in older adults, with American incidence around 151 cases per 100,000, appearing more often in women and in people of European ancestry. Vegetarians and vegans carry elevated risk for the obvious reason. Pollack and colleagues reviewed the literature in Nutrition Reviews in 2013 and in the European Journal of Clinical Nutrition in 2014, and the deficiency rates they compiled span a wide range from 11 to 90% in adults, and the elderly, 21 to 41% in adolescents, 25 to 86% in children, and 62% among pregnant women. Rates run higher in vegans than in vegetarians, and higher again in people vegetarian since birth. The EPIC Oxford cohort found up to 52% of European vegan adults deficient. India deserves particular attention, given how much of the population eats vegetarian by tradition. Ref. Som and colleagues documented high cobalamin deficiency among Asian Indians in the American Journal of Clinical Nutrition in 2001, using elevated methylmalonic acid and homocysteine as markers. Yajnik's work found roughly 70% of vegetarian Indians showing biochemical deficiency. Naik and colleagues, publishing in the British Journal of Nutrition in 2018, studied 119 young, healthy vegetarian Indians and found about half deficient, 50 to 70% with low holotranscobalamin and 70 to 90% with elevated homocysteine. Every one of those participants was asymptomatic. A recent Indian meta-analysis puts pooled prevalence at roughly 51%, with a confidence interval running from 44 to 57%. Medications add another layer. Metformin lowers serum B12 by somewhere between 14 and 30%, and confirmed biochemical deficiency affects an estimated 5.8 to 30% of long-term users. Monitoring, in practice, barely happens. Longo and colleagues reported in Pharmacy Practice in 2019 that among 322 patients on at least 1,000 milligrams of metformin for 6 months or longer, only 25% had a B12 level measured across a 5-year look-back. Proton pump inhibitors and H2 blockers reduce the stomach acid that frees B12 from food, and long-term use has been associated with deficiency, documented by Lamb and colleagues in JAMA in 2013 and in a young meta-analysis in 2015. Bariatric surgery, which bypasses portions of the absorption route, carries prevalence around 30%. Malabsorptive diseases range from 6 to 38%. One cause of B12 deficiency is growing fast enough to have triggered federal warnings, and it affects a much younger group than everything covered so far. Nitrous oxide, sold recreationally as whippets or laughing gas, oxidizes the cobalt atom at the center of the B12 molecule and inactivates it. Methionine synthase stops working, and users develop functional B12 deficiency with myeloneuropathy and subacute combined degeneration. What makes this dangerous to diagnose is that serum B12 can look completely normal on a blood test, since the vitamin is present but chemically disabled. Methylmalonic acid and homocysteine testing catches what serum levels miss. Peer-reviewed case reports through 2024 and 2025 have accumulated in Curious, Neurology, and Radiology case reports. The scale is not small. The 2023 National Survey on Drug Use and Health reported that more than 13 million Americans have misused nitrous oxide at some point in their lives. CDC data show nitrous oxide poisoning deaths climbing from 23 in 2010 to 156 in 2023. The FDA issued safety alerts in March and again in June of 2025, warning that inhaling nitrous oxide can cause vitamin B12 deficiency, along with prolonged neurological effects, including spinal cord or brain damage, even after stopping use. Michigan's chief medical executive, Dr. Natasha Bagdasarian, said in a state health release in June of 2025 that the increases in nitrous oxide misuse are concerning, given the widespread availability of the product. Michigan Poison Center calls rose 533% between 2019 and 2024. Emergency medical responses rose 553%, and emergency department visits rose 757% between 2019 and 2023. The United Kingdom banned recreational nitrous oxide in 2023, and Health Canada issued warnings and recalls during 2025. Two testing problems make this deficiency harder to pin down than most. The first involves folic acid. High folate intake can correct the anemia caused by B12 deficiency, normalizing the blood picture while neurological damage continues progressing underneath. How nor, the hematological alarm bell gets silenced, and the nerve damage carries on. This concern intensified after mandatory folic acid fortification of grains began in the United States in 1998, since fortification raised folate intake across the entire population. The second problem is that serum B12 is an unreliable measurement on its own. Methylmalonic acid is the more sensitive marker, with values above 0.271 micromoles per liter suggesting deficiency. Homocysteine above 15 micromoles per liter also suggests deficiency, though it rises for other reasons too. Holotranscobalamin, often labeled active B12, is more specific than total serum B12 because it measures the fraction your cells can actually use. Cutoffs are genuinely contested, and that disagreement explains most of the confusing statistics you encounter. North America generally treats deficiency as serum B12 below 148 picomoles per liter, while Japan and parts of Europe apply lower limits closer to 350 or even 550 picomoles per liter. NHANES data from 1999 through 2004 illustrates the consequence perfectly, because the same population showed 3% prevalence at a threshold of 200 picograms per milliliter and 26% at 350. One population, one dataset, two answers, depending entirely on where the line gets drawn. The Schilling test, which used radiolabeled B12 to distinguish pernicious anemia from other malabsorption causes, has largely disappeared from practice. Radioisotope handling, procedural complexity, and the unavailability of labeled intrinsic factor reagent pushed it out. On screening, major bodies do not recommend testing everyone. The American Academy of Family Physicians advises testing people who have a risk factor combined with a clinical feature, which is precisely the combination this video has been describing. Food sources are the starting point. Fish, meat, poultry, eggs, and dairy all supply B12, and beef liver stands out as one of the richest sources available, delivering about 70.7 micrograms in a 3-ounce serving, which comes to 2,944% of the daily value, according to USDA and Office of Dietary Supplements figures. Fortified foods, including cereals and plant milks, matter enormously for anyone eating plant-based, along with nutritional yeast. And they hold a mechanical advantage for older adults because the B12 in them is already free of protein binding. Supplements work, and the form matters less than the marketing implies. Methylcobalamin and adenosylcobalamin are the two metabolically active forms in humans, while cyanocobalamin and hydroxycobalamin convert into active forms after absorption. Cyanocobalamin is the most common supplement form. It is inexpensive, and the body converts it readily. The old assumption that serious deficiency requires injections has softened. A 2018 Cochrane review by Wang and colleagues, pooling 3 randomized trials with 153 participants, found that high-dose oral B12 at 1,000 to 2,000 micrograms can normalize serum levels comparably to intramuscular injection. Evidence quality was rated low, and injections still have their place, particularly where absorption is completely blocked. But oral therapy is a legitimate option for many patients rather than a second-best compromise. Now, for the claims that do not hold up, because several of them appear constantly in health content about this subject. Probiotics improving B12 absorption has no solid human clinical evidence behind it. A 2024 rat study in Food and Function found certain lactobacillus strains raised absorption by 14.5 to 71.2%, and mechanistic reviews exist. But human trials have been mixed and inconclusive, as a 2021 systematic review in Nutrients concluded. Kefir and kombucha are fermented foods containing live cultures, which is a fair description of what they are, and there is no evidence they boost B12 absorption. Dark chocolate is not a probiotic at all. At most, it supplies prebiotic substrate. Spirulina, most seaweeds, and tempeh are unreliable as B12 sources, and this misconception has real consequences for people eating plant-based diets. They contain mostly pseudo-B12, inactive coronoid analogs the human body cannot use, and which may interfere with the uptake of genuine B12. B12 as a general energy booster fails on the evidence too. The Office of Dietary Supplements states that supplementation appears to have no beneficial effect on performance in the absence of a nutritional deficit. B12 shots sold for energy to people whose levels are already adequate are not supported by the research. Fix a deficiency and energy returns because you were deficient. Add B12 to a body that has enough and nothing happens. The history explains why B12 deficiency stopped being a death sentence, and it moved faster than most medical stories. James Scarth-Combe, a surgeon in Edinburgh, presented the first case in 1822 and published it in 1824 in the Transactions of the Medico-Chirurgical Society of Edinburgh, describing an anemia nobody could explain or treat. Thomas Addison of Guy's Hospital in London described idiopathic anemia in 1849 before a lecture to the South London Medical Society. For roughly a century after Combe's paper, the disease earned its name because pernicious meant exactly what it said. The break came in 1926, when George Minnow and William Murphy at Harvard published in JAMA on treating pernicious anemia with a special diet, reporting around 45 patients who improved by eating large quantities of liver. Their work built on George Whipple's studies of anemic dogs at the University of Rochester. In 1929, William Bosworth Castle identified intrinsic factor in the American Journal of the Medical Sciences, explaining why the liver worked and why some patients could not absorb what they ate. The Nobel Prize in Physiology or Medicine followed in 1934, awarded jointly to Whipple, Minot, and Murphy for their discoveries concerning liver therapy in cases of anemia. Nobody yet knew what molecule in the liver was doing the work. Mary Shaw Shorb at the University of Maryland built the tool that found it, developing the Lactobacillus lactis Dorner assay in 1947, which made rapid measurement possible for the first time. In 1948, two teams isolated the vitamin as red crystals almost simultaneously. Carl Folkers and colleagues at Merck in the United States, who named it vitamin B12 and published in Science, and Ernest Lester Smith's team at Glaxo in Britain. Structure came next, and it took 8 years. Dorothy Crowfoot Hodgkin at Oxford began the X-ray crystallography work around 1948 and published the crystal structure in Nature in 1956, revealing the cobalt-centered corin ring at the heart of the molecule. Her Nobel Prize in Chemistry arrived in 1964, awarded for her determinations by X-ray techniques of the structures of important biochemical substances. Building the molecule from scratch fell to Robert Burns Woodward at Harvard and Albert Eschenmoser at ETH Zurich, who completed the total synthesis in 1972 and published in Pure and Applied Chemistry in 1973. The project consumed 11 to 12 years and involved around 100 collaborators, which remains one of the more striking measures of how complicated this vitamin is. fatigue that sleep does not resolve, muscles weaker than they should be, a tongue gone smooth and red, skin turned pale or faintly yellow, and vision fading in both eyes at once. Those are the 5, and the pattern matters more than any single item on the list because every one of them appears in other conditions too. What separates B12 deficiency from most health worries is the arithmetic of time. Liver reserves lasting 1,000 to 2,000 times your daily requirement means symptoms arrive slowly, which sounds reassuring and is not, because slow arrival means the deficiency has usually been running for years before anything shows. Some damage reverses beautifully, with tongue lesions clearing within about a month of supplementation. Some damage does not reverse, as those 24 optic neuropathy patients demonstrated, where 25% recovered completely and 29% recovered nothing at all. 3.6% of American adults are deficient, 12.5% are insufficient. And among specific groups, older adults with absorption problems, vegans and vegetarians, long-term metformin users, people on acid-reducing medication, patients after bariatric surgery, and anyone inhaling nitrous oxide, the rates climb far higher. A blood test settles the question in a day. Treatment costs very little. And the same test that finds a deficiency early is the one that catches it before the permanent part begins. If you recognize 2 or more of these 5 signs in yourself, ask a doctor for B12 testing, rather than diagnosing yourself from a video. And mention any risk factors you carry, because that combination of risk factor plus symptom is exactly what clinical guidelines say should trigger the test. This video covers general information and is not medical advice, and it is not a substitute for diagnosis or treatment by a qualified clinician. If it was useful, subscribing and hitting the bell brings you the next one. Thanks for watching.